What is brachytherapy for prostate cancer? How effective is it when compared to prostate surgery, traditional radiation therapy, or things like cyberknife or proton beam therapy? What are the side effects? Do you need to be on ADT after brachytherapy? What if you have Gleason 8 or 9? Can you still do it? How much does it cost, and is it covered by insurance? What else should you know? Well, today I have the expert in brachytherapy in the United States, Dr. Ajay, to answer all those questions.
Yeah, my name is Dr. Ajay Bhatnagar. I am the founder of Prostate Cancer Institute of America. I'm a radiation oncologist by training, but I like to call myself an interventional oncologist. And so while the past 20 years, I have practiced radiation oncology, the past 3 years ago, I decided to solely focus on prostate brachytherapy for multiple reasons. And so therefore, this being an intervention, I like to call myself an interventional oncologist rather than a radiation oncologist, because what I do is much different than what a typical radiation oncologist does that oversees external beam treatment.
Perfect. Look, at this stage, I'd like you to introduce, now we have heard about different radiation treatment methods. There is the traditional IMRT, then there is cyberknife, there is proton therapy. Could you tell us a little bit, for the men watching this with prostate cancer, what is brachytherapy?
That's a great question. So the simplest way I'd like to describe it is that, you describe forms of external radiation. Brachytherapy is a form of internal radiation. So here we're directly delivering the radiation source and placing it in the tumor and delivering that radiation directly to the tumor. Now, this allows us to give us a much higher dose of radiation to the tumor, since we don't have to go through all the other normal critical tissues like we do with external radiation. And so by giving a much higher radiation dose directly to the tumor, we are able to have a much better outcome, in meaning a higher cure rate with much less side effects.
Wonderful. Okay. I'd like to hear more. So I'm going to ask you some questions. But first, I'd like to ask you, are there different types of brachytherapy? And what should a man with prostate cancer, considering to have a treatment, who hasn't had a treatment yet, what should they know about the different types of brachytherapy?
Yes. So the traditional, most established form of brachytherapy for prostate cancer is low dose rate, LDR. I know a lot of people say low dose, but it's actually giving the highest dose. It's just giving it at a slow rate, which is actually very convenient for prostate cancer, because that's a relatively slow growing tumor. And this is the direct delivery and permanent implantation of these seeds that are slowly giving off radiation to eradicate the prostate cancer. Then there is high dose rate brachytherapy, a bit newer technology, and this allows for a temporary implantation of a radioactive source in the prostate that's delivered just over a few minutes. Again, this is temporary and just over a few minutes, not really consistent with the radiobiology of prostate cancer being slow growing, and therefore requires multiple sessions of implanting this radioactive source in the prostate temporarily. The big issue here is that with low dose rate brachytherapy, the doctor, the radiation oncologist, is placing these seeds precisely in the prostate, assuming they are trained in this. With HDR, there is a remote afterloader that actually temporarily places these seeds in the prostate. And therefore, it can actually be somewhat easier for a facility to offer HDR, since you don't require that skill set for the doctor to place the seeds, since the machine and the computer is doing the work for HDR. So here we have LDR, that's 30-minute one-time procedure, to HDR, where we're talking about several hours. It can somewhere be 4 to 8 hours and several sessions for HDR brachytherapy. And so a huge difference between the two. And I'm obviously much more biased for LDR because of its convenience, its radiobiology, consistency with prostate cancer, and the data. The data is there for LDR. Over 30 years of data to support the efficacy of LDR brachytherapy for the treatment of many different types of prostate cancer.
Wonderful. I think you touched upon a topic there that I'd like to come back to, because you said at some point that it is easier for a facility to provide HDR because it requires a lower skill set. And this is something, so when I work with, I'm not a medical doctor, but I collaborate with a lot of medical doctors, and I work with men with prostate cancer with a lifestyle. And I do make them aware that the skill of either the urologist who performs the surgery or the skill of the basically the technician of even a CyberKnife machine matters. It's not just you sit under a machine, they press a button, and the outcome is the same. Still, the skill set of the doctor matters. And now you said that even though HDR, it is a much more, it takes more effort to perform because it requires multiple sessions. I've heard some bad stories. I've heard stories from patients that I work with that they had, when they did the HDR, that they had to be in the hospital for, as you said, hours with their legs up, with different needles stuck directly into their prostate, coming out of their body with cables, delivering radiation. And yeah, as you touched upon it, it might be because it requires a lower skill set. You also said that a lot of these newer technologies, when we were talking, you and I, before that, a lot of the newer technologies that deliver radiation therapy, such as proton beam or MRI LINAC or CyberKnife, they still go through external tissues, and some of them go the tissues at the back as well. That's why they have to put spacer gels. Why do we need to do that if we can just target the radiation directly into the prostate without having to go through the skin first, or a bigger zone that touches multiple organs and tissues like the traditional IMRT? So would you say that LDR has, are there any benefits of LDR that are better, let's say, or they deliver benefits that cannot be replicated by other technologies, even the newer ones like proton therapy and CyberKnife, or these other technologies have benefits that LDR doesn't have? Can you comment on that?
Yes. LDR brachytherapy is the most conformal radiation treatment for prostate cancer. In this treatment, we are delivering 125 gray when using palladium-103 radioactive isotope. External beam doses generally range from 70 to 80 gray, okay? And so it doesn't take much to figure out when you are giving 40 to 50% higher dose safely, you can have a higher cure rate. And when you look at the data, there is definitely an improved local control rate with LDR versus external beam. ProstateCancerFree.org is a great website that compares the different treatments, and I would invite you to look and see. the disease-free survival rates with brachytherapy versus external beam radiation therapy. This treatment allows us to give such a high dose that even for some high-risk prostate cancer patients, we don't even require as much ADT anymore. The recent study showed us in Japan where they randomized patients that got external beam and brachytherapy with 6 months of ADT versus 30 months of ADT, and there was no difference. And so these men now that typically get 2 years of ADT, I only recommend 6 months because of them getting the brachytherapy. That high dose of brachytherapy reduces their duration of ADT. Okay, proton beam, MRI LINAC are all still forms of external beam where they still need to get 2 years of ADT almost. And so that's a big deal. As we know, that can be the most symptomatic aspect of their treatment for these patients with Gleason 9 and 10 prostate cancer. And so thereby adding brachytherapy to their treatment paradigm, we've now reduced their requirement of ADT, which I believe is a very big deal. And that study is fairly new, but no one talks about it because no one does brachytherapy anymore. But that's because of non-clinical reasons.
I'm going to ask you about that a bit later. You actually answered my question. I wanted to ask you if ADT is still required if you do brachytherapy, and you answered that yes, but the time that is needed is actually could be much lower. So with 6 months it's all that you need versus 2 years that mostly, and now it's mostly used than with external beam radiation therapy. Well, my next question would be...
But I would like to point out, because intermediate risk category, because let's face it, many patients are in this intermediate risk category, Gleason 7. And that's where many patients are getting external beam and a short-term course of ADT, 6 months to a year. In that cohort, there is no benefit of adding ADT to brachytherapy. So intermediate risk patients that get brachytherapy do not require ADT for the radiosensitization. Some do get it for maybe downsizing the prostate to make it more amenable for the prostate size to be a candidate for brachytherapy, but we don't necessarily need it to increase the radiosensitization to improve the outcome like we do with external beam, because like we said, we're giving 50% higher dose with LDR brachytherapy, and therefore we don't need that enhanced radiosensitization that ADT offers. And that's a big deal because, as we said, the ADT can cause a lot of side effects, and it can also take a long time to testosterone levels to return and normalize. And so it has a big impact on quality of life that we now can eliminate this requirement by just offering brachytherapy alone for this fairly large patient cohort of intermediate risk prostate cancer patients.
Yeah. So you talked about intermediate risk, which is, a lot of now Gleason 6s, they just go on active surveillance. So we're talking about Gleason 7. Would a Gleason 8 or 9 be still a suitable candidate for LDR? And what if there is a bit of a spread locally, at least stage 3, when there is spread in the lymph nodes?
Yeah, these are typically candidates for combination. So we can offer brachytherapy as well as pelvic radiation, as well as a short course of ADT, not a long course. And this really improves the outcomes. The other advantage here now is that instead of the external beam being 9 weeks, typically when for these high-risk patients, we can be now shortened to 4 to 5 weeks. So the combination brachytherapy and external beam for these high or very high-risk patients can provide significantly improved outcomes compared to external beam and ADT alone or surgery and ADT, while also significantly reducing the duration of ADT required.
I see. Now, a lot of patients, when they go to the urologists and the urologist recommends radical prostatectomy, especially if they don't prepare well, and they don't do also physiotherapy after correct physiotherapy by someone who gives them specific exercises for prostate cancer. They experience, about 80% of men experience erectile dysfunction, and about 30% experience a form of urinary incontinence, because there are different types of urinary incontinence. How do these side effects compare in prostatectomy, radical prostatectomy or robot-assisted prostatectomy versus low-dose brachytherapy?
Excellent question. Brachytherapy has been shown to have the highest erectile function preservation rate compared to external beam and surgery. The data shows that it's about a 76% preservation rate, okay, compared to a 50% with external beam and about a 34% preservation with surgery from the data. But empirically, I can tell you it's really more about their baseline level of function coming into the procedure. If they have a good level of function before the brachytherapy procedure, they're going to have a good level of function afterwards. If they have a bad level of function or inability to have erectile function, the treatment obviously is not going to improve that. It's the borderline cases that we have to address, where their function is declining, but still has adequate ability to have erections. Those patients, I really take close care in providing the post-immediate surgery care of them taking, the PD inhibitors, like, low dose of Cialis for that 1 to 2 months after the radiation to increase that blood flow, has been significantly shown to improve their erectile function preservation rate. And even with external beam too. So, the erectile function preservation rate is the highest with LDR brachytherapy, and a big reason why many patients come to see me.
Wonderful. 2 more side effects I want to ask you about. So one is, after radical prostatectomy, the man loses their ability to have ejaculate. So if they have sexual erectile function, they would have dry orgasms. And when we go to radiotherapy, a lot of men, just by radiotherapy alone, even without combining it with ADT, they will experience fatigue. How does LDR compare to having ejaculate when it's compared with surgery? And how does it compare with fatigue when it's compared to external beam radiation therapy?
Great questions. In terms of the ejaculate, there tends to be, since the prostate function is to produce additional seminal fluid to the semen, there is a reduced amount of fluid. Is it zero? It can depend. But people are still able to have adequate erections and orgasms. But yes, there tends to be reduced amount of fluid. In terms of the fatigue compared to radiation therapy, the daily commitment of external beam radiation, whether it's some cytokine production or it's just a daily commute, whatever it is, there is definitely a fatigue factor related to this daily treatment. With brachytherapy just being a one-time treatment, there isn't that fatigue. And so that's a big deal. And so logistically and functionally, I have patients that are playing pickleball the next day. I have patients that are going to work the next day. And so that's really important. A patient in particular that I saw was a young man that was offered surgery, but he owned a pool cleaning company. And he basically was told by a surgeon that he wasn't going to be able to work after surgery. And that would have killed his business. And he could not have done that. I mean, this was a business, this is a small business owner that ran his pool company that had to be outside working. And he came to me asking me about the ability to work after brachytherapy. And he was able to work right after brachytherapy with no significant issues. I usually tell patients no heavy lifting for 1 week, but otherwise, you'd be surprised about the minimal downtime involved with brachytherapy. And so therefore, he did not have any significant fatigue. He was able to continue his business, and very, very thankful that he was able to find me.
I'm quite surprised. To be honest, I haven't, when it came to seed implantation brachytherapy, which is what you're talking about, low dose rate brachytherapy, I actually only had 2 men that I used to work in Australia have that, and that was quite a while ago. In United States, I haven't heard anyone do it. So I thought that was an old technique that for some reason wasn't good enough, and it got replaced. But it sounds like even when compared to newer radiation treatments like proton therapy or external beam radiation, and also when compared to prostatectomy, it has significant benefits still. So I wonder if it was a better technique, a better method to address prostate cancer, why is no longer popular?
That's a great question. And that's exactly why I started this practice, because the story of brachytherapy in America represents exactly what's wrong with our healthcare system here in America. Here you have the most conformal radiation treatment for prostate cancer and the most cost-effective treatment for men with localized prostate cancer. But that's exactly why no one does it anymore, due to the more lucrative treatments that are now more available. And so this happened around 2007, the early 2000s, and the continual decline of this treatment has led to now its death today, where there's no one even trained in this procedure anymore. The training programs don't even offer training. So it's gotten to even to that point where it's not even available. And that's the reason why I started this practice, to make this treatment available to men across this country that are candidates and interested with this procedure, because this needs to be an option for all men with prostate cancer that are viable candidates.
Wonderful. And as you said, it takes most skilled radiation oncologists to do that rather than the other techniques. So it is more lucrative to have more of the exotic new techniques, because they can charge more to the Medicare or to the insurance, whereas the old school, even though it still could be better than the new ones, because it involves more skill, they wanted to outsource skills to the machine, basically, so they can scale up and have more patients, more volume of patients coming in, rather than quality of outcomes, would you say?
Totally agree. But I do also want to say that there are some modern aspects of brachytherapy. We have the ability to do real-time planning. So right in the operating room, we're able to calculate the doses and figure out where we should place the seeds and the needles to create an adequate dose to the entire prostate while sparing the critical structures, mainly the urethra. And therefore, this real-time planning is a big deal, because before we would use preoperative images and preoperative planning, and things can change from before surgery to the day of surgery, especially when they're on ADT, and that really is a big deal. The advances in imaging, we can now, such as MRI and finding these dominant lesions, we can now place the seeds directly in these lesions. We can fuse the MRI to the ultrasound and have increased dosage to those tumors, and we can also do focal brachytherapy for these patients that only have minimal disease burden and don't want to do treatment to the entire gland, not exactly sure about active surveillance. And the focal brachytherapy is a great option, because we can treat that isolated lesion and follow them closely. And if they do fail somewhere else, we can repeat brachytherapy. to those other areas. So this treatment doesn't necessarily limit you, and it allows you to actually have subsequent brachytherapy treatments because it's so focused and not damaging anywhere else. And therefore, there are quite a few modern aspects. I didn't even get a chance to tell you, Dr. Georgios, but I did write a book last year on modern LDR brachytherapy that's in Amazon. And so that highlights the modernization of this treatment that makes it even more efficacious.
Wonderful. I'll put the link of the book in Amazon in the description for men watching this if they want to read it. We're also going to put your contact information. Where are you based?
I'm based in Arizona, but I'm across the country. I'm in 10 states. So, we also offer virtual visits to see us virtually, and patients can either fly in to one of our locations, Denver, Las Vegas, Phoenix. We're also in North Carolina, New York, all over the country. And we hopefully will continue to expand to make this treatment accessible for patients all over the country. We also take all the types of insurances, including the VA insurances, Medicare, all the private insurances. So we really want to make this available to everyone. And I do have patients that come from all over the country and that fly to come to visit me for this treatment, but I'm also expanding horizons to go elsewhere. But I can tell you, Scottsdale, Arizona right now in November is a pretty nice place to visit.
Yeah, good. Well, actually, I was going to ask you about the insurance next question, so you got me. Yeah, you answered that. Now, I wanted to comment that I know, well, I was surprised to hear about low-dose radiation therapy, and I'll definitely be informing people that this thing exists. I won't tell them to go and do it because that's medical advice, but I will tell them to go and send you an email to contact you and see if there would be a good candidate for this treatment.
The main issue with brachytherapy is prostate size and urinary function. I don't like to, if their prostate size is over 80 grams, the normal size, they will have much more side effects. And so therefore, I do not recommend to treat them at that size. However, there are multiple ways now to shrink the prostate. Okay. I mean, obviously the traditional way is ADT, but there are a lot of side effects with ADT. So men may not like that. Some can even just take a medicine just like finasteride to get a 20-30% reduction. But there's also now this new procedure called the prostate artery embolization, PAE, that can reduce the prostate to more than 50% reduction over a period of months, and has been quite effective. And I've had several patients undergo that procedure and then have brachytherapy with excellent outcomes. But yes, the prostate size tends to be one of my biggest factors of identifying who's going to be a good candidate, because the number of seeds implanted is based on the size. So if the prostate size is really big, that would then require a lot of seeds, and that would cause a lot of irritation. And therefore, I don't do that. I like to make sure these patients are ideal candidates because I do want them to like me after the treatment.
Yeah, that sounds good. If a man decides to do low dose rate brachytherapy with seed implantation, will he still need some sort of like a spacer gel between his rectum and the prostate?
That's a great question. So I do offer it, and I do actually give it. It allows me to put the seeds at that posterior border more, because also I can place the gel at the same time as brachytherapy. I call it a 2-for-1 special. So then why not? I mean, it's not another procedure. It's at the same time. So when I can offer this at the same time to further improve it, but is it absolutely vital to need it compared to external beam? Technically, no, but is it helpful? Yes. And can I do it at the same time as a brachytherapy? So then why not? But combination treatment where you're getting external beam and brachytherapy, those patients absolutely need it because we're giving twice the amount of radiation. And that's really when I started doing combination, is when the spacers came out. And that's why now I don't see any rectal toxicity with combination therapy, which used to be the biggest criticism of combination therapy, was the higher toxicity, which we don't see anymore. Another category of patients that we need to talk about are salvage patients that have failed external beam radiation. Okay, and what do we do with them? Because surgery is really not a good option. Low dose rate brachytherapy is the standard of care for patients who have failed external beam, and these patients are at risk for rectal toxicity. So I highly recommend that they get SpaceOAR at the time of their brachytherapy. So that's, you brought up an excellent point. So my final thing, yes, I do recommend it for the combination and the salvage patients. It's very important. But if I'm already in the OR offering this treatment, even for the other lower risk or intermediate risk patients, just getting brachytherapy alone, it's still helpful. So why not?
Wonderful. Now, I want to ask you a bit of just your personal opinion, which a lot of these sort of like targeted therapies are coming out now. One of them is Pluvicto, which is lutetium, if I remember correctly, lutetium-177, which is what? It can be categorized, I think, as a form of brachytherapy, but more like systemic, because it's labeled sort of like it is an antibody that goes and connects to any cell in the body that has the prostate, the PSA on its membrane, and it's radioactive. So you inject it in the body, this circulates around with whichever cell has PSA, which is the prostate cells, both prostate cancer and healthy prostate, and whatever metastases, it goes and connect and sort of like slowly give the radiation dose there, but the rest of the cells are unaffected. You pee it out. Do you think, first of all, I want you to comment if I was right. You're the medical doctor.
That's exactly correct. This is a form of brachytherapy, and it's internal brachytherapy. So the difference here is that with the low dose rate brachytherapy, we're using a sealed source. The seeds, the radioactivity is contained in the sealed source, those seeds. This is an unsealed source. So here we're now giving this radioactivity through the vascular system that can then go throughout the body systemically. So this is using what we call an unsealed source to deliver brachytherapy and the internal radiation. And therefore, it is really ideal for these patients that have cancer throughout the body, where we have a targeted antibody, the PSA, the PSMA molecule. And so therefore that treatment, Pluvicto, can give radiation doses wherever there is the PSMA molecule or the prostate cancer, and provide a great outcome. So this is now not only going to be used for prostate cancer, but for a wide array of cancers where we have a targeted antibody that we can attach a radioligand, a radioactive molecule, to kill that. And so this is really, really exciting. The interesting part is that, radioligand therapy has been around for many years. It just hasn't been as popular as it is now. And I think, that we're getting better in the technology, and we're now able to image it better. But this is not a new concept to radiation oncologists. It's just that it's blowing up now. This is the future, not only for advanced prostate cancer, but for a wide array of other diseases.
I wanted to ask you, just seeing into the future, I wonder one day if we will be able to deliver a much better treatment for men with prostate cancer if we combine seed implantation brachytherapy, so low dose rate seed implanting brachytherapy, plus this sort of like radioligands, as you said, systemic brachytherapy, lutetium-177 or other ones, and bypassing ADT. So bypass all the top.
That's a great theory. And I really like that, because when we're able to treat the source of the cancer with the LDR brachytherapy, and then with the RLT, we're able to treat any other systemic areas without having to do ADT. There was already a study that came out this year's Astro, the LUNAR study, where they combined SBRT with RLT for these patients with metastatic prostate cancer that were hormone sensitive, and they showed a doubling of improvement in the progression-free survival compared to getting SBRT alone. So you're now taking it one step even further to provide a real cure when we kill the cancer at the primary source with LDR. So I completely agree with you. It's very exciting. More is yet to come. This is just the beginning.
Wonderful. Dr. Adi, this was super helpful for me, first of all. I learned a lot. I will definitely be sending a lot of the men that I work with your way. And I hope men watching this, both in the US, but throughout the world, to prompt them to research more treatment pathways and treatments that are not exotic and new, but sort of like going in a way that would be more like, what is the outcomes, what is the statistics, what is the side effects? Yes, this is new, this is exciting, but is it really more effective than the old one that is covered and it's cheaper and it's covered by my insurance? And also it is way less invasive, takes one procedure, I'm done, and it's done. So I hope it will sort of like start the discussion, start men thinking, and hopefully give men around the United States and the world better care and cure.
Totally agree. We need to revive this treatment that's gone away for the wrong reasons. I really appreciate your enthusiasm for supporting this cause. Thank you so much for letting me be on today.